I'm delighted to bring Emily Miller up next.
Thank you. It's going, okay. Slipping through the cracks, suicide risk in student athletes. Death is not an entirely foreign concept to the sports medicine physician. They spend quite a bit of time screening athletes for risk factors for sudden cardiac death. However, the numbers are sufficiently low that I was not expecting to have any encounters with death during my brief sports medicine rotation in residency. My patient was an elite athlete and a graduate student living in the dorms. During a training camp out of state, she sustained a concussion and was evaluated by her team physicians. She then returned to school with a full course load and continued her training uninterrupted, despite having ongoing post-concussive symptoms that were aggravated by exercise. A few weeks into the semester, she attempted suicide. She had a very well thought out plan that was very likely to succeed and sustained a mild anoxic brain injury. She was then admitted to the inpatient psychiatric unit for about 6 days and discharged to follow up at an intensive community day program. However, she felt that they did not understand the demands of elite athletics, and it was also conflicting with her training schedule, so she quit the program. She did notice, however, that as she returned to training, her post-concussive symptoms seemed to be worse following her suicide attempt. She then presented to our clinic at the General Student Health Center. This was about 1 week after her discharge from the hospital. After extensive discussion about her current symptoms, her goals, we collectively developed a concussion management plan. And she really seemed to understand the rationale. She agreed to cut back, both physically and academically, to beneath her symptom threshold in order to allow her brain time to heal. However, she was very frustrated by the lack of a concrete timeline for which she could know when she was going to be able to return to full training and competition. We set up for her visits with the club sports athletic trainer 3 days a week to go through the vestibular exercises. And she was going to follow up with us in 2 weeks after returning from an additional training camp. I also contacted her psychiatric case manager, who's assigned to every patient when they get discharged, who planned to stay in contact with her very closely over the next week due to our concerns. And I attempted to set up outpatient psychology appointments for this patient. I talked to her on the phone 2 days later, and she seemed optimistic. She stated that her symptoms were better controlled with our current management plan, and she denied any suicidal ideation. 5 days later, we received a call in clinic. She had committed suicide that night. It took me months to work through my feelings of frustration and grief and loss and failure. I felt that I had invested so much time and energy into trying to arrange follow-up for her, and it felt like all of my efforts had been futile. Her entire medical team knew that she was at a very high risk for a second suicide attempt, and yet it felt like there was nothing that we could do. Over time, I came to accept that there's only so much that we as healthcare providers can do to prevent someone from committing suicide. There's never one single reason that someone's able to commit suicide. I wish I had called her a second time that week, but likely that wouldn't have made a difference. And many of those factors are controlled only by that patient. During that same rotation, I then met with 2 additional student athletes who had active suicidal ideation. And I realized that the problem was much more pervasive than this single case. I came out of this experience knowing that there was something we had to learn from this tragedy, and with a determination to increase awareness of mental health illness among student athletes, and a desire to create safeguards for these athletes when they're at their most vulnerable. College athletes are less likely than their peers to commit suicide. However, there are specific populations of student athletes who are likely at a much higher risk. Many elite athletes have equally lofty athletic and career aspirations, leading to significant overcommitment and stress. These athletes in particular are very prone to anxiety regarding performance expectations and subsequent failure-based depression when perhaps those expectations were not met. On another note, especially with undergraduate student athletes, they tend to form homogeneous social networks based on their athletic participation. So when you have an injury that restricts their team participation, it's also cutting them off from their social network. And as this period can be prolonged due to a severe injury, or if they have difficulty returning to their prior level of play, this can be a significant trigger for depression-type symptoms. In extreme scenarios of retirement from sport, these symptoms are then further aggravated and at a higher risk. Many of these athletes' self-identity is intricately tied to their sport and their athletic ability. So when you take that away from them, they go into a sort of identity crisis, putting them at a very high risk for depression or suicide. Concussion is a multifaceted injury that has significant risks that you don't get with other injuries. For example, in addition to restricting their athletic participation, it also affects their academic performance, which for many of these athletes is attacking them from two fronts. Second of all, the lack of a clear, concrete timeline for recovery can be incredibly stressful for type A perfectionist type student athletes. And then finally, many symptoms of a concussion actually increase your risk of suicide by themselves. These symptoms can include mood symptoms like depression, anxiety, and emotional lability, and also cognitive symptoms like lack of impulse control, attention deficits, or difficulty with decision making. Neuroimaging findings have actually identified findings in the cognitive and emotional processing centers of your brain following a concussion, and these findings have been correlated with clinical depression in athletes. In a recent systematic review and meta-analysis, the relative risk of suicide after a concussion at any point was 2 times higher. One could postulate that in the immediate aftermath of a concussion, while the people are still experiencing symptoms, this risk for suicide would be even higher. Varsity athletes have an extensive medical safety net, which usually includes athletic trainers, physical therapists, and physicians. However, it may or may not actually include mental health providers. At Stanford, we do have 3 sports psychologists now who are instructed to work with all elite athletes at the university. However, as I went on fellowship interviews this year, this is not often the case at other universities. For non-varsity athletes, however, they are lumped in with the general student population. And as everyone is aware, mental health illness is extremely prevalent in university situations. So many of these community psychologists or psychologists at university or the mental health services for university students are overbooked, overscheduled, difficult to get in contact with, and difficult to schedule appointments with, leaving them without a good mental health safety network. I wanted to talk specifically about a few key areas that potentially could benefit from an intervention. First of all, with the elite non-varsity student athletes, this is a very vulnerable population since they are separated from their traditional medical support team, potentially over state lines. These athletes have all the pressures of varsity athletics without the support care team in place. I believe that these athletes should be integrated into the varsity medical team safety net. Next, all elite athletes deserve to have mental health services available to them. Whether this is designated sports psychologists who are on your staff or a relationship that you've formed with a community psychologist who's open to seeing your athletes and has experience working with elite athletes and is prepared to work your patients into their clinic. In any case, they need to have close access, easy access to mental health professionals. And then finally, the college dormitory setting is a very dangerous place immediately after a suicide attempt. Patients are admitted to the hospital for a suicide attempt and then discharged back to their dorm, where they may or may not be even friends with their roommates. And it's a lot of pressure to put on an 18-year-old roommate to support their roommate after a suicide attempt. The disability rights activist group has actually sued universities for encouraging encouraging students to take a leave of absence after a suicide attempt, however. So universities feel their hands are tied due to these restrictions. I don't know the answer to this question, but I do feel that all groups need to get together and come to some sort of middle ground. So in conclusion, every provider who works with college-age students needs to be aware of their increased risk for mental health illness and suicide risk. And those who work with student athletes in particular need to have a low bar for referral especially after an injury or concussion, when these athletes are at the most high risk. Those working, every elite athlete should have access to mental health services. This is very important for their mental health well-being, and it's very prevalent in sports medicine world. And then finally, physiatrists in particular emphasize the multidisciplinary team approach. In inpatient teams, we've integrated psychologists into all of these teams. They're an integral part of the team, and this approach needs to be adapted and taken into the sports medicine world so that we have mental health services available for these athletes. Thank you for listening to my talk, and I hope you come away from this with a better understanding of suicide risk in student athletes and also a desire to create change in your world. Thank you.